So what we have right now in the perioperative setting is adjuvant nivolumab is approved based on CheckMate 274. So in this trial, as we know, there was an improvement in overall disease-free survival, as well as disease-free survival more robustly in the PD-L1 high population. We also know from a recent update at the EAU meeting in 2024, where we saw an improvement in overall survival, which was a secondary endpoint. Apparently, the statistical bar was not met. However, there was clearly a strong trend for survival improvement. So that drug is out there for adjuvant therapy, approved in Europe in PD-L1 high patients only, and in the US in all comers. Now, what we also have is the adjuvant pembrolizumab trial, Ambassador, that led to an improvement in disease-free survival in all comers. So that is still not approved, but we anticipate it might be. And now more recently, we've heard, of course, that the NIAGRA trial is positive. This is a neoadjuvant trial, not adjuvant. So it's a neoadjuvant trial comparing gemcitabine cisplatin versus gemcitabine cisplatin plus durvalumab. And there's also an adjuvant component of durvalumab alone in the experimental arm, including durvalumab. So this trial has been reported as positive in a press release, improvement in both event-free survival as well as overall survival. So that's a very positive report from that trial. So based on that, I would anticipate that all of the other chemo IO trials might also be positive. You can anticipate EV plus pembrolizumab potentially also could be positive based on the very dramatic results seen in the advanced disease setting, first-line setting with EV pembrolizumab. So really, I think there is a lot of dramatic changes going to happen in the perioperative setting based on all these trials. NIAGRA is likely to be practice-changing. We are still waiting to hear from the results, full presentation of the results. Hopefully this will be at the ESMO Congress 2024, we're not sure. But yes, I would anticipate that to be practice-changing. But I do anticipate other trials testing the same chemo, cisplatin-based chemo plus PD-1, PD-L1 inhibitor combinations to also be positive based on the fact that NIAGRA is positive. And I would also anticipate EV pembrolizumab combination to be positive. So really, I think that there will be a lot of regimens, including immune checkpoint inhibition, that will come in that space. So at the moment, we still are lacking prospective validation of ctDNA for MRD, molecular or minimal residual disease assessment. But there is obviously a good retrospective data to show that post-operative ctDNA using tumor-informed ctDNA, using whole exome sequencing of the tumor and picking the top genes to look at in the blood has looked very promising, which was based on a retrospective analysis of the IMvigor010 trial, which showed that if you're ctDNA positive post-op, your chance of recurrence is very, very high, more than 90%. While if a ctDNA negative, you have a low chance of recurrence, not a zero chance, but a low, like a 25% approximately risk of recurrence. So potentially this could be used to select patients for adjuvant therapy or not. The prospective validation of this platform is ongoing in the IMvigor011 trial. And we have heard some data preliminarily from a group that was continuously ctDNA negative in that study. That is a study in which patients were randomized to atezolizumab or placebo when they turned ctDNA positive all the way up to a couple years out. And so what they reported so far is patients who are ctDNA negative continuously for almost up to a year and a half, approximately 16 months median. What we know is that in that group that was continuously ctDNA negative, their chance of radiographically having recurrence was low. It was not zero, it was low, around 10%. So that suggests that ctDNA negativity continuously is a good prognostic factor. Your chance of recurrence is low, not zero, but quite low. So that's what we know. I think that we need further validation, more data from IMvigor011. Also a second trial called the Tombola trial, which is also examining this. There are also other platforms that are emerging. One of them is whole genome sequencing of the tumor to select ctDNA molecules in the blood. So it's also tumor-informed, but based on whole genome sequencing of the tumor, not just whole exome sequencing. So that's one. And there's yet another one behind that, and that would be fragmentomics. So not only looking at ctDNA based on the individual genetic alterations, but also looking at fragments of the way the DNA is broken up in these tumor cells, which is a little different. There are smaller fragments from tumor cells than normal cells. So this is called fragmentomics. So all of these are going to, I think, emerge in the future.